All right, guys, welcome to Road to 250. Today's topics will be Togaviruses, heart defects, and then we're going to talk about 2 drugs and then call it a night. So, let's start with Togaviruses. So, could somebody tell me the characteristics? RNA virus, is it single-stranded, stranded?
Single-stranded.
Okay. Single-stranded, positive or negative? Single-stranded. Positive, correct. Is it enveloped or non-enveloped?
Envelope.
Correct. So it is enveloped. It is a single-stranded positive RNA virus, which is a linear. And then what's the shape?
Icosahedral.
Correct. Icosahedral. What diseases does Togaviruses cause?
Rubella.
Correct.
Equine encephalopathy.
Nice. Equine. And
chikungunya.
So today we're only going to talk about these 2. I haven't put anything for chikungunya today, but just know it's a Togavirus. All right, so Rubella. So what can you tell me about Rubella?
It's a Togavirus.
Correct. It's caused by a Togavirus.
Part of the torch of infection.
Okay. All right. So this one, I'm kind of giving you general characteristics, but it's also known as a German or 3-day measles. It's caused by Togavirus. And how is it acquired? You guys know? So it's acquired via inhalation of respiratory droplets. And what can it cause?
Fever?
Fever, rash. I heard rash. I think.
Okay, yeah,
yes.
I was saying rash.
So the rash occurs 1 to 5 days after the fever. If you look online, there are some places that say 2 to 3, some places that say 1 to 5. So we're just going to say in general 1 to 5. And it starts on the face and it goes centrally down to your trunk. It does cause fever. And then lymphadenopathy is another big one. Do you know the locations of the lymphadenopathy with rubella?
Periauricular?
Yep. Post-auricular or posterior cervical are the 2 spots that are commonly coupled with lymphadenopathy. And the vaccine, obviously, is the MMR vaccine. All right, so we're just going to talk about congenital rubella syndrome. So we'll see, you said it's a torch infection. Can you guys name me the other torch infections? Just as a quick review.
Toxoplasma.
Toxoplasma, yes.
CMV.
MV.
HSV.
HSV, which one? Type 2.
Type 2. And
so you said toxo, rubella, cytomegalovirus. You're missing another H and then an S.
hepatitis.
HIV and syphilis.
Syphilis.
Correct. So, mom would acquire it via respiratory droplets, and the symptoms the mom would see would be rash, fever, and lymphadenopathy. Yay. What is the clinical triad for a fetus? What would you see in a fetus who got rubella?
Blueberry muffin.
Okay, so yes, but I'm looking for 3 specific things. That is classic triad for a fetus.
Cataracts.
Deafness. And one last one, that's the major topic for today, is heart disease.
PDA.
Correct. So congenital heart diseases include PDA and pulmonary artery stenosis. So yes, you're right. It can cause a blueberry muffin baby. So they do have a blueberry muffin rash. Do you guys know why that is? Why do they get this?
Petechial hemorrhaging?
Okay, so it basically in utero.
Extramedullary hematopoiesis.
Correct. Extramedullary hematopoiesis occurs outside of the bone marrow and typically occurs in the dermis layer of the skin. So this normally stops prior to birth, but if it persists, the baby can get this blueberry muffin rash, as they say. So, diagnosis. How do you diagnose it in a mom? So you're looking for IgM antibodies in the mom. That shows a recent infection. And then amniocentesis. That shows virus in the amniotic fluid. So here's basically what first aid has, and we've kind of went over everything here. Again, it's a torch infection and congenital. Yes, you're going to see blueberry muffin, but there's another slide I'll show you where you're going to see the other symptoms. So deafness occurs both in cytomegalovirus and rubella. So does blueberry muffin. So these two are very common, right? So how do you differentiate CMV versus rubella is the other symptoms that you're going to see. In CMV, you're going to see seizures and then hepatosplenomegaly. But in rubella, you're going to see cataracts or congenital heart diseases. So just clinically, you're going to see the same thing as far as deafness and blueberry muffin baby. So just keep that in mind. And this is from the torches infection section of first aid. Again, you get respiratory droplets for rubella. This is what mom would see is rash, lymphadenopathy. And then the classic triads are cataracts, deafness, and congenital heart disease. While cytomegalovirus, not only if you see a question with the same kind of topics or symptoms. All right, so equine encephalitis is another thing that can be caused by Togavirus. So there's a western and an eastern separation, and they can infect both humans and horses. The viruses reside in birds, and it's transmitted by mosquitoes. So most infections are asymptomatic, but it can cause encephalitis, and you would see fever, mental status changes. And Eastern is the worst type. So the way you can think about this is triple E is always bad. So it's a mosquito transmission, and triple E is always bad. And so this is just a quick picture to show you that it's usually between mosquitoes and birds. It keeps going back and forth, and then we're just, additional targets essentially, and it's like a little bridge. So any questions about this? By the way, that's Pete when he goes camping out in the future.
I like a mustache.
So any questions before we move on to the concept? All right, so let's talk about basic principles of heart disease or congenital heart defects. So, 1 second. Okay. So it arises during embryogenesis, so usually between weeks 3 and 8. Defects are sporadic, and it results in shunting. Shunts between left and right circulations. How do these present?
Cyanosis.
Between left to right.
Oh. Left to. So late cyanosis? Like later, not at birth?
Yes, later. So presentation at birth is going to be asymptomatic, but the shunt will eventually reverse, causing the cyanosis in later years. And there is a term for that. I'm not asking you that term right now. I know you guys know it. We'll talk about that in a few minutes. And then shunting from right to left usually presents with early cyanosis, and that's shortly right after birth. So those are how you differentiate. So today we're just going to talk about the left to right shunts. So typically, as we know, blood goes this way. So normally left-sided pressure is always greater than the right-sided pressure. These are just general what you would kind of see in left atria and right atria, the pressure, just to show you that normally left-sided pressures are greater. And left to right connections equals left to right flow. So when you have a VSD, which is left ventricle to right ventricle, or ASD, it's always flowing from the left to right side. and PDA, obviously, from the aorta to pulmonary artery. So this is just to tell you what we're going to talk about, just more words. So at birth, your left to right flow kind of leads to volume overload in the right heart. But your heart can compensate. Your heart can accept that large amount of volumes. But the blood flow to the lungs remains unimpaired, so you have no cyanosis. However, years later, you're going to increase the flow, makes the pulmonary vessels thick and stiff, and then this is when you're going to get the right ventricular to hypertrophy and the right side pressures to rise, and then the shunt reverses and cyanosis then occurs. What is that called? When cyanosis occurs later on in life due to right ventricular hypertrophy and right side pressure rise. Eisenmenger syndrome. So that's typically where we're going to head to after we go through all that. We'll talk about Eisenmenger syndrome at the very end. Okay, so ventricular septal defect. What do you guys know about this generally?
It's normally in the membranous portion. It's normally a congenital issue with the IV septum, failure to fuse with the cardiac cushions.
Okay. All right.
Oh, most of them. Oh, is the most common.
Correct.
Most
Congenital.
common congenital defect, and most of them sporadically close.
Correct. All right. So Pete kind of summarized quite well, but I'm just going to say what I have to say. So defects in the septum that divides the right and the left ventricle. As he said, it's the most common congenital defect. What is it associated with? What syndrome?
Downs?
Okay, no. That's another one that you're thinking.
Tetralogy of flow.
Fetal alcohol syndrome. So it's commonly all of these are associated with fetal alcohol syndrome, but this is most commonly associated. Again, it's a left to right shunt, and VSDs are characterized by size, location, and associated defects. So small defects are usually asymptomatic, and large defects usually lead to volume overload and heart failure. Talk about that in one slide. So treatment for these are usually surgical closure, and small defects will probably close spontaneously. So most common congenital cardiac defects, so this is from first aid, essentially, and may manifest weeks or later, remain asymptomatic throughout life. Most will resolve. Larger lesions will go to heart failure. Okay, so what is the big difference with VSD in size? So when you have a small VSD, you have a tiny hole. So it resists the flow across the defect. So it's called a restrictive VSD. You're going to hear a lot of turbulence, and you hear a very loud murmur. But the shunt volume across the defect is not very much. So you hear a loud murmur and say, wow, there's something there, and the patient would be worried. But it's really a benign condition because not a lot of volume is being crossed. However, when you have a large, it's non-restrictive. The flow is great. And so there's significant shunting, and then this has to be optimally closed surgically to prevent volume overload or right heart failure. So that's the difference between the sizes. Even though you hear a loud murmur, doesn't necessarily mean it's a bad thing. But when you have a large VSD, it can be a bad thing because it can go to overload and right heart failure. So any questions with that before we move on? All right, so ASD. So this is a defect in the septum that divides the right and left atria. A common type of ostium secundum. Ostium primum is associated with what disease? Pete, your first guess was right on this one.
Downs.
Down syndrome. And this is left to right shunt, and it's split S2 on auscultation. What causes the split of S2? So it's increased blood to the right heart, delays the closure of the pulmonary valves. So aortic and pulmonic valves close together, But if the blood is higher, basically because there's a shunt, it adds more volume to the right atrium and right ventricle. So that delays the closure of the pulmonic valve, as the right side of the heart has to pump more blood relative to the left side. So that's why. And that causes the wide fixed splitting of the S2. And then that will also increase the flow across the pulmonary valves and the tricuspid valves. So that's why you might hear a systolic ejection murmur or a rare but mild diastolic murmur. Depending on where the flow is greater, you could hear those two differences. And what's the most important complication with this one?
Heart failure?
No, it's paradoxical emboli.
Yeah.
So basically, the big key things that you want to take forward is wide fixed split S2. And we're going to talk about the secundum and ostium primum in a few seconds. And then symptoms, you could see heart failure and then the O2 saturation in the right ventricle may lead to paradoxical emboli because they bypass the lungs and become systemic atrial emboli. So they're pretty sure it can cause you a stroke. Actually, I've had a family member who has this exact defect, and she got a stroke because an emboli crossed and went to her brain. So with ASD, it's very important to keep that in mind. All right, so what are we talking about here? With the secundum type, usually it's a defective site at the foramen ovale or the ostium secundum. And there's multiple reasons why this happens. And most of these are often isolated, and they're located in the mid-septum. So here, this is going to be your septum secundum and your septum primum. So if you guys follow the normal heart embryology, this is going to collect to the cushion, endocardial cushion. So the foramen ovale basically will, when the pressure is too high, it opens to allow the shunting. And this is common in fetal circulation. But there are multiple reasons why the secundum type of ASD can occur, and that's possibly due to the septum secundum being too short. So if it does not, come down as much as it should, it will always leave this opening hole for the blood to cross. Or if the septum primum has an excessive reabsorption, because you're needing a little a gap essentially to keep the blood flowing in high pressure situations. If it reabsorbs too much, it'll always constantly leave this big gap in between. So this is the most common type of secundum issue, and I hope that makes sense. Anybody have questions about it? And so this is a picture that I found, and it just shows that, sorry if I clear all my pen colors, but there's a big gap right here. And that's what you're looking for. And then the primum type, obviously, is basically the septum primum fails to, just want to make sure I'm not saying anything right. Yeah, it fails to fuse with the endocardial cushion as it should. This fusion should occur. So when it fails to do so, it kind of leaves this opening. And these are typically located at like the AV valves and often occur with other defects. This type will often occur with other heart defects. And these are seen in endocardial cushion defects such as Down syndrome. So you're going to see a patient with Down syndrome could possibly have the ostium primum type of ASD. And here's a picture. It's your atria and your ventricles. And as you can see by this picture, it's right here. And it's close to your ventricles, so it's closer to your AV valves. So that's essentially what this picture was trying to show you. Any questions? All right, then we'll move on to PDA. And normal ductus arteriosus shunts blood in utero from your left pulmonary artery to your aorta. Well, I have a picture from first aid about this in a few slides. But after birth, it should close. So the functional closure occurs within 24 hours due to your smooth muscle contraction. And then the anatomic occlusion occurs over the 2 to 8 weeks. And it becomes your ligamentum arteriosum. So, and patency is maintained by prostaglandin E1, E2. And placenta is the major source in utero. So failure of ductus arteriosus to close. What is that associated with? So what is PDA associated with? What disease that we've discussed today?
Well, today, it's the coarctation of the aorta, but
Rubella.
Congenital rubella,
Oh,
correct.
duh.
Results in left to right shunt between the aorta and pulmonary artery. It's asymptomatic at birth with a continuous machine-like murmur and may lead to Eisenmenger syndrome and results in a lower extremity cyanosis. So here's a picture of the fetal circulation. And my major points that I want to cover with you guys is these three things, obviously. But majorly, deoxygenated blood from your SVC passes through the right atrium and right ventricle and to the main pulmonary artery, but it bypasses via the ductus arteriosus to your descending aorta. And the shunt is high in fetal pulmonary artery resistance due to the low O2 tension. So at birth, when the infant takes breath, the resistance drops in the pulmonary vasculature, and it increases the left atrial pressure. So the foraminal valve will close, and basically this foraminal valve right here will close, and then that's where the regular circulation occurs. Does that make sense?
Mm-hmm.
So just keep that in mind. And obviously, Indomethacin is a drug that we're going to talk about today, and then there's another drug that's a prostaglandin E1 agonist. Okay, so this is directly from first aid. So in fetal period, shunt is right to left, which is normal. But in neonatal period, due to the decrease in vasculature resistance, shunt becomes left to right. And that can progress to right ventricular hypertrophy or left ventricular hypertrophy and heart failure. So it's associated with a continuous machine-like murmur. There's one other thing that I want to talk about. With PDA, you're going to see what increased pulse pressure. Does anybody know why? Sorry, that was a bad drawing. But so normally your blood pressure will rise to 120 and then let's say it falls down to a diastolic pressure of 80. In PDA, due to the loss of volume in the atrial tree, this diastolic pressure can actually go down as low as like 30 or 40. So that will increase your pulse pressure, essentially. So I've seen it in questions where they don't directly give you that this patient has PDA, but they can say that it has an increase in pulse pressure, and that's typically because of the loss of volume in the atrial tree. That's causing the diastolic pressure to drop even lower than it should. And then that's why you get an increase in your pulse pressure.
Or they'll be assholes and just give you the patient's blood pressure is a 120 over 40, and you just breeze over it and don't realize.
Yeah.
So wait, what is the mechanism between the increased pulse pressure?
It's due to the volume loss in the atrial tree through PDA. It's low diastolic pressure drops even more than it normally would because of the low pressure, and that's why there's an increase in pulse pressure.
Okay.
And here you have differential cyanosis, which is basically when the shunt goes from right to left. It affects the toes. So the lower extremities would be cyanotic, but your fingers would be normal. So that's another way they could say that this patient's toes are cyanotic, but his fingers are okay. And that's just a differential cyanosis, which can occur in PDA patients. Any questions?
Mm-hmm.
Cool. So as we said earlier in the beginning, that uncorrected left to right shunts can eventually lead to cyanosis and clubbing and polycythemia. So this is Eisenmenger syndrome, and that's increased pulmonary blood flow, basically leads to a remodeling of the vasculature, causes your pulmonary atrial hypertension, which then causes right ventricular hypertrophy as a compensation mechanism. And that's what causes the shunt to go from right side to left side. And the polycythemia is just because, from what I've read, was due to an increase in the hematocrit, and chronically low O2 tension stimulates EPO release, so you get a high hematocrit. And the age will vary in onset because it can happen. So when typically you think of Eisenmenger syndrome, think of kids instead of babies. So when you look at right to left shunts, they say cyanotic babies or blue babies. But with Eisenmengers, you're going to think of blue kids because it occurs later on in life and not right at birth. So that's a good way of differentiating the two. So if nobody has any questions, we can move on to the drugs for today.
Sounds good.
So Alprostadil is what?
I'd say PGI.
It's a
Also
prostaglandin E1
E1.
agonist. Yeah. So it maintains patency of ductus arteriosus, and the key effect that it has, it delivers blood to the lungs, and it's useful when you have poor right ventricular to pulmonary artery blood flow, such as in tetralogy of Fallot and pulmonary atresia, but can also be given in patients with a PDA. And then the next drug that we're going to talk about is Indomethacin. And Indomethacin obviously is an NSAID. So what is its mechanism of action?
COX-1, COX-2 inhibitor.
So it inhibits cooxygenase. And what does that do? What does COX do?
Causes vasoconstriction.
Okay. I'm thinking broader, just saying decreases your prostaglandin formation. So, and it can be used to close PDA. So what are some adverse effects of Indomethacin? Or NSAIDs, let's just say in general, what are some adverse effects?
GI ulcers.
Correct. Gastric ulcers. Yeah,
Gotcha.
because your
And then-
prostaglandins help protect the gastric mucosa, and if you take it out, it's not going to help you protect it.
And bleeding because decreased platelets.
Correct. And how about anything to do with the kidneys? Yeah.
Oh yeah, nephritis, interstitial.
Interstitial nephritis, and there's one other thing. It can
Artery.
cause renal ischemia because the prostaglandins vasodilate the afferent arteriole, but if you don't have prostaglandins, it can't do that, so it can cause renal ischemia. The aplastic anemia is the other one. So, any questions about this? Cool. So I have 2 questions for you guys. A 6-year-old boy presents to the physician with poor exercise tolerance. Physical exam shows a wide pulse pressure and a continuous murmur. First of all, let's just say, what is that?
Holosystolic.
Continuous murmur.
PDA.
Yeah.
PDA. He's diagnosed with a congenital disorder of a structure that shunts fetal blood from the pulmonary arteries to the aorta. If you need one more clue, it's right there. Which of the following therapies for the mother would have reduced the risk of conceiving a child with this disorder?
Give them the D.
D is correct. MMR vaccine, because you gotta think that the PDA is associated with congenital rubella, so rubella you can be prevented with an MMR vaccine. All right, and one more. A 13-year-old child has a 1-month history of bluish gray discoloration and several week history of dyspnea and decreased physical activity. The child's birth was unremarkable, and he has otherwise been healthy and active. Heart rate is 95, respiratory rate's 21, and blood pressure is 113/72. There is a moderate clubbing of the distal extremities and continuous murmur best heard at the left, second, and third intercostal spaces. Complete blood cell count reveals a white blood cell count of 8,100, hemoglobin of 17.1, hematocrit of 54.3, and platelets of 224,000. Which of the following is the most likely cause this patient's condition?
A.
You are correct. Basically, it's a left to right shunt, and it's distinguished clinically from a right to left shunt. And so instead, this one has, basically the patient will develop pulmonary hypertension leading to right ventricular hypertrophy. Eventually, the pressure on the right side can exceed that on the left side and cause Eisenmenger syndrome. But this patient had a PDA. That is correct. Any questions?
I should probably stop recording.
Okay, I actually kind of have a question or something I'm just having a hard time visualizing in my brain. So it was about the ASD and how you talked about they have the split S2. So it's a wide, fixed split S2. And I get that in general you get splitting and it's normal when you have like increased inspiration because so much blood is coming into the right ventricle and there's delayed closure of the pulmonic valve. Now, what I'm confused about is how that works. So that's the normal, and now you have this ASD. I'm just like, I don't know. Someone want to talk it out?
Because so let's think about this. We have the physiologic split, which is one layer. Instead of hearing boom, 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 you hear boom, 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 boom. And that's because as you inspire, you have more venous return to the right side of the heart. That means there's more blood in the right heart to pump out through that pulmonic valve.
Yes.
Now, if you have, from like Yash was saying, in an ASD, left to right shunting, so that means extra blood is going from the left atrium to the right atrium to the right ventricle. So you've got constant extra blood supply to the right. So it's always going to be closed later, right? So like a fixed split.
Fixed. Yeah, fixed. Okay. Yeah, that makes sense now. Thank you.
If you want, it's on page 277 of 2017. That's where the fix split.
Oh, okay.
So it's written exactly like I just kind of mentioned, but again, you just need to picture it.
Okay, yeah, thank you.